There are many types of biomarkers that are useful in all areas of cardiovascular disease management. Some biomarkers are used to help identify a patient's risk of developing a disease or for providing evidence of subclinical disease. Other biomarkers help physicians recognize overt disease or categorize its severity. Prognostic biomarkers are particularly useful for identifying aggressive disease and for predicting how a patient may respond to therapy. While biomarkers are clearly useful in the management of cardiovascular disease, there are still some limitations. For example, it is well known that inflammation plays a key role in the atherosclerotic disease process. It's not surprising that numerous studies have examined the measurement of inflammatory markers and their association with cardiovascular disease. Some have begun to reveal weaknesses of these biomarkers. A perfect example is that while most studies show a dose-response relationship between hsCRP levels and risk of incident coronary disease, association to sudden death and peripheral artery disease has been modest. Other evidence also shows that hsCRP is a poor predictor of the extent of atherosclerotic disease. Cystatin C is a marker that is often used to predict risk of secondary cardiovascular events, but it's unclear if it's a direct marker for disease or just a marker for renal failure. Serum amyloid A is another inflammatory marker that, like hsCRP, has also been shown to have a modest association to sudden death and peripheral arterial disease. Some known limitations also extend to fibrinogen, which is frequently used to predict stroke and cardiovascular disease. But the causal relationship between high levels and increased cardiovascular risk is unclear. Finally, some of the newer lipid biomarkers have come into question because none were proven to be superior to total cholesterol and HDL-C risk prediction scores in a large study of over 165,000 patients. Recently, we've seen PLA2 enzymes emerge as biomarkers that are associated with atherosclerotic disease. These enzymes are a family of proteins that catalyze the hydrolysis of phospholipids at the SN2 position, which yields pro-inflammatory lysophospholipids and fatty acids. As a result, the products of this hydrolysis can trigger multiple pro-inflammatory actions. In fact, researchers have recently discovered that there is an important link between SPLA2 activity and atherosclerotic processes. Secretory phospholipase A22A, or SPLA2-2A, has a well-established role in inflammation and atherosclerosis. Here we have just a few of the studies that have documented its role. Researchers have demonstrated in animal studies that overexpression of human group SPLA2-2A is related to atherosclerotic lesion development. Other studies suggest that SPLA2-2A may be an important factor in initiation, progression, and/or rupture of atherosclerotic plaque. And the body of evidence supporting the association of SPLA2-2A to cardiovascular conditions continues to grow. Increased plasma levels of SPLA2-2A have been linked to recurrent events and adverse outcomes in patients with stable coronary artery disease. They were also predictive of recurrent cardiac events and death in patients with acute coronary syndromes, including myocardial infarction and unstable angina. Watch video 2, which summarizes the significant results of these pivotal clinical studies.